Hi, and welcome to episode 170 of the Untethered podcast. Today we have Dr. Skye Zeller joining us. Skye moved to Connecticut in 2008 for grad school, completed her master's and PhD in microbiology at Yale in 2014, and then dental school at UConn in 2014 to 2018. Since then, she's been a general dentist working in community health and as an associate at a private practice in Wolcott. She started sleep and airway focused practice, Dental Sleep Experts of Connecticut, in 2020 and recently became owner of the General Dental Office in January 2022. Outside of work interests, she has two twin 8-year-old boys, and they enjoy spending as much time outside together as possible, skiing, hiking, climbing, and exploring. Quick disclaimer, all information, content, and material of this podcast are the opinions of the speakers and is for the informational purpose only and not intended to serve as a substitute for the consultation, diagnosis, and/or medical treatment of a qualified healthcare provider. Welcome to the Untethered podcast. I am your host, Hallie. I'm a certified orofacial myologist, feeding specialist, and mentor. This podcast is all about getting your questions answered and collaborating with colleagues to bring you the most up-to-date information in the orofacial myofunctional therapy, tethered oral tissue, and airway space. I challenge you to keep an open mind and join my mission to get this information out to the masses. Let's get started. Skye, thank you so much for joining me on the podcast today.
Thanks for having me. I'm excited.
I love having conversations with airway-centric providers who just get it. So I'm excited to kind of dive into that topic today. And I would just love for you to share with our listeners, like, how did you get into this space?
Yeah, so honestly, I dove into this just shortly before the world shut down for COVID. And really, I had started just by taking my very first class on sleep and airway and mandibular advancement appliances for adults. And I took one class, I spent the weekend there, and I was like, this is really cool. And then my father-in-law, who is, approaching his 70s, has been practicing dentistry for 40 years now, has always been preaching early ortho airway, to the point where he was doing it before it was a thing. He had a lot of orthodontists who would badmouth him and say that early ortho intervention is just a waste of money. And he just stuck to this. And so when I took my first adult airway course and I saw all we're really doing is providing space and bringing the lower jaw forward. And then I kept listening to everything he was saying, early ortho, we need to bring that lower jaw forward. You need to expand and bring the lower jaw forward. It just kind of made sense to me that now I needed to figure out how you treat children. Because if we can actually grow people out of this and fix them early, then we're not making them appliances that are Band-Aids for the rest of their life. And I was just blessed with twin boys who were my perfect starting point. So I actually had one son who would end up in the emergency room pretty much every month, all winter long with croup. The best response we got from the ENT was that he had a floppy airway and he would probably outgrow it. And so I started taking more classes on that. And when I went back and looked at his pictures from when he was a baby, every single picture was open mouth posture, low resting tongue position, mouth breathing. And so we started working on that part of it. And, all through the beginning of the pandemic, we were training nasal breathing. We were working on expansion. And he's a completely different kid now. So
that's been a really exciting,
cool ride for him.
I mean, he sounds very similar to my 4-year-old. So my 4-year-old had croup on and off. And there was one time where we ended up in the emergency room with croup, RSV, she was having febrile seizure. I was like, something's got to give. Why can't anybody help us? And we weren't there every month. Like you said, you were, she never had a laryngomalacia diagnosis or floppy airway diagnosis per se. But I was like something's up, why? And now she, and then they're like, oh, she's pre-asthmatic. And then she was on Flovent inhalers over the summers when we were living up north. And I'm going and we would keep dexamethasone and rescue inhaler, on hand just for whenever these flare-ups happen, so we could avoid going to the emergency room, especially during the pandemic. And it was okay, why are we not talking about what's causing this? Why are we just kind of, again, like you said, you're just slapping a Band-Aid on every symptom that presents repeatedly. And she, even this year at age 4, we moved to South Florida, but she had croup, I think 3 times in 6 weeks. It just kept coming back and we kept going to urgent care. And I kept being hey, like, we know what this is, like, what gives, right? And of course, like, no one helps. They're just kind of like, well, she's got a fever, let's give her this medicine. And she's got croup, let's give her this medicine. And so I was like, all right, that's it. I did early expansion with my older daughter who didn't have these kinds of issues that Mia had, but she was like that picky eater, tongue-tied baby, you know, all kinds of other things going on. Always jutting her jaw forward, licking her lips and becoming like raw around the lips. And I'm like, she's basically putting her mandible into the position that her body needs. Like, hello, people,
Yeah,
you know? And so
exactly.
we did expand her with an ALF appliance from like 4 to 5. And that was like during the pandemic, you know, beginning part of it. And then she's actually going into some additional expansion starting in a couple of weeks, maybe next week. I'm like, I don't even know. So I'm excited because we need to bring her mandible forward a bit more. But my youngest is starting as well because she's just got that deep bite. You know, she's got all the things, and it's really fallen, I feel like, into the laps of dentists and orthodontists who are more airway centric and understand like that early intervention component, but it's so hard to find.
Yeah, and two things. One, I grew up in South Florida, so welcome to my former home. It's a lovely place to
Thank you.
be and an awesome place to raise kids for sure. But what I've been so excited about over the last, I would say like year and a half, is that we've created this incredible team within like the central Connecticut area, consisting of myofunctional therapists and speech therapists and ENTs. We have a couple of really amazing pediatric ENTs in our area who just get it now, to the point where I'll get, you know, reports over to me that's like, I'm not gung-ho about surgery yet. Like, let's see what you can do with expansion first. And if you think that we really need to dive in, we will. And so like understanding it on that level is incredible to me. We have sleep doctors now who get it both from a pediatric and from an adult standpoint, because I do a lot of outreach about like, yeah, we can actually expand adults. So when you see your patients and they're crowded and they're narrow, and really the tongue is the primary obstructor, like we can help that. We can do stuff to make more tongue space, and we can train them to breathe through their nose, and we can get involved at this point. And instead of having them on those Band-Aid solutions for the rest of their life, I mean, if they're 30, that's 60, 70 years of quality lifetime that they're going to be missing. So we've been able to really just build this super cool network lately.
Awesome.
Everyone seems to be on the same page, and it's really helpful to the patients, which I think is the most important part.
Yeah. And that's like one of the things I get asked the most because I run this membership with myofunctional therapists, and they're like, where do I find the team? And do you know anybody in this area? And we're like constantly trying to connect people. And we're like, look, you know, to some degree, you're going to have to also work with providers in your area to build that team because, you know, obviously everybody has to be open to learning, but sometimes learning together is so powerful too, because then you kind of sit down and look at these cases and it's like, what gives? Like, how can we stop these symptoms from recurring? Like, what is the root cause of what's going on? And so I get so excited when I hear that like people have created teams, and you know, it's so needed, but you got to put the work in for sure.
Yeah, and if I could give like the smallest piece of advice in doing that, every patient you see, write up your findings. Find out every doctor who's involved in their care, whether it be their primary care doctor, their ENT, their sleep doctor. Write it up with pictures and send it. Because once you see these things as a provider, like you can never unsee them. So like, I don't think many of the providers I worked with really understood like how important tongue mobility is, to be able to elevate the tongue, to be able to grow the maxilla as a child, but then also as an adult to ensure that the tongue's not being tethered down and back into the airway. And so now when I point this out and I send the pictures, all of a sudden I have people coming in that are like, my sleep doctor told me that they think my tongue's tethered. Like, can you look? And like things like that, that is like so interesting to me. Cause I know that you don't learn that in medical school. You don't learn that in dental school.
You don't learn that in school for SLPs. It's like all post-grad, you know, education. Yeah. So what age groups do you work with in your practice?
So we see the whole gamut actually. I will start looking around 2. And I'll steal one of Kevin Boyd's comments, like you treat as soon as the kid is ready to be treated. So there is no such thing as too early. It's really just when the kid is emotionally immature enough to deal with what you're doing. And I do have some 3-year-olds that I have in expanders at this point, because they need them. They need them and they're ready. And we can make them look really pretty. And sometimes we have sparkles and sometimes we have dinosaurs and the kids get very excited about them. and the parents buy in, and then they see the difference in the symptoms, and it's amazing. So we treat as young as 3. And then I do treat all the way up into the 80s and 90s. You know, I do a fair share of mandibular advancement appliances. We work with Medicare, and we do what we can to help everybody get the treatment they need.
That's amazing. So you're basically evaluating airway in every patient that walks through your door.
Yeah. So I recently bought a general dental practice in January, and my father-in-law's practice, actually. And
Congratulations.
Thanks. He had been doing this for so long, but it's interesting. Now I have his hygienist seeing things more through the lens of airway. And I'll be doing something, and our hygienist, Blair, who's actually training now to become a myofunctional therapist as well, she'll be like, Doc, can you just take a look? Because I think I see something. And it's so interesting. Once you learn to see these things, the lens that you see every patient through and all of the problems that they're having is completely different. So we're pretty aggressive with perio in our office, but now that we're learning that there's a huge link between periodontal disease and mouth breathing, right? Now we know that, like, a lot of these patients that we've been treating for so long, let's look at them through this other lens, and wow, they really don't have lip seal, and they really do have low tongue posture, and they really are breathing through their mouth all day long, drying out the periodontal tissues, allowing plaque to really stick to the teeth, and causing a lot of these problems. And it's the same thing with, like, decay. Obviously you need to investigate diet, you need to investigate all of those things. But when you see a kid with rampant decay and mouth breathing, right, narrow arches that they can't get into, after you rule out diet and brushing and hygiene, then what else is going on? And how do we help these kids from now until they're adults so they're not losing teeth?
Yeah. I feel like I've been hearing this conversation a bit lately of, it's yes, it's important what we put in our mouth, and yes, oral hygiene is a very important component, but so many dentists will say, like, oh, you must not be flossing well enough, or, oh, you're giving your kids too much sugar, or, oh, this, that, and the other. And it's like, well, hold on. Has anybody looked in the child's mouth, under the tongue? Is the mouth open at rest? How about when they're asleep? And I feel like I'm excited to hear these conversations happening more. I feel like we're like still at the earlier side of this though. And we definitely need more, what sort of looking for, not exposure, but I feel like it really, I was talking to, Dr. Stacy on last week. She actually, her podcast just aired. And we were talking about how, like, the gut microbiome was, like, kind of a new thing 10 years ago, but now everybody knows about it. And we're, like, hopeful that the oral microbiome is, like, going to be where the gut microbiome is, another 10 years from now, where everyone's just talking about, like, is your mouth open or closed? Like, are you a mouth breather? Where's your tongue? Like, why can't your tongue go up there? What's going on? Maybe your jaw's not in the right place. At least just some initial things to get the conversation started so that we normalize the conversation, because we see that so many of these symptoms are common, but not normal. And that's, like, one of my most favorite things to say, common, but not normal. Like, it's, we see these things so frequently now that everyone's just like, oh, but everybody does it, so it's fine. Well, no, it's not.
Yeah, I gave a talk to a group of local dentists a couple months ago. And one of the big things I was saying, like, I showed just all these pictures of kids sleeping, right? And it's like the initial reaction is, wow, that's so cute. And then you look again, and these kids have open mouth posture while they're sleeping, necks up like this, trying to get air. Some of them are even, like, snoring. You can see struggling, blue circles under their eyes, like, whatever it might be. And then it's like, do you see this now? Oh yeah, now we see it, right? This is not normal, even though it's common, and this is not cute. Right. Those are the two big things.
Yeah. I mean, it's, our society is basically not just normalized it, but made it sexy to mouth breathe. Like, models have open parted lips, and, it's like a sexy thing to have your lips a certain way. And, and there's all these shirts with, like, lips on it with, like, lips apart, and so it's just what the brain sees and knows. So it's, we kind of basically look at it as, like, oh, well, that's how things are supposed to be. So I struggle with that. I'm like, oh, it's a cute shirt, but, like, no, I can't buy that because the lips are not together.
They're putting lip tape on the shirts.
There you go. That's so funny. So
conversation.
In your practice, like, you're using basically myofunctional orthodontics. Are there, like, specific appliances you use? You use, like, a range of appliances? Like, what does that look like for you?
Yeah, so we're always trying to learn more. I think as providers, we get very set on appliances and not necessarily on big picture ideas. So for me, I'm always like, let's start with a huge picture, and then we can start to incorporate smaller aspects of that as we go. So for my big picture idea, it's every kid needs to have enough space in their mouth for their tongue. I don't really care about their teeth and their tooth mass. That's going to come as they get older. And if we need to do some bonding on small laterals, like those are all fine. It's not about the teeth ever. It's about the structure. And so finding ways to increase the size of the mouth, and that depends on the kid. It depends on compliance. It depends on personality. It depends on what the parents want and are willing to get behind. And then making sure that the skeletal relationships are right, that we're getting forward growth, that we're getting the mandible coming downward and forward as this kid is growing, and that all of the muscles are working to continue to promote that proper growth throughout the whole course of growth and development. So if I look at a kid and the key issue is a tongue tie and they're slightly narrow, then my treatment plan looks something like myofunctional therapy, frenectomy, and let's start with myofunctional orthodontics for a while to get all of that under control. If I have a kid who's having croup every month and can't breathe, then we're pushing forced expansion and we're doing it quickly. Because for me, most important is making sure that those kids are asymptomatic. And then we'll start worrying about the rest of it, like the myofunctional piece and the myofunctional orthodontics after that. But almost every kid I have, whether they're in, straight wire brackets or fixed expansion or removable expanders or myofunction, they're always in some kind of a myofunctional program at the same time. Because I feel very strongly that no matter what, if you don't address the underlying problem, say I treat at 6 or 7 and the kid still has a tongue thrust, well, by the time he's 8, now we've got flared incisors and a retreated mandible again. So we need to get those habits under control. Things went wrong for a reason. They didn't just go wrong. They went wrong because the muscles were out of control, or the habits were out of control, or the tongue wasn't doing what it could, or the kid couldn't breathe. Mm-hmm. And now if we don't address all of those aspects, then it doesn't matter what I do. I tell the parents, I have a cool slide I show a lot of parents that just involves all of the members of the team. And, I'm probably 25% of the overall outcome. I can make your kid look awesome, but it doesn't matter if we don't have the other 75% involved, because my 25% will only last as long as it lasts.
Right. And I think that's really cool that you have like that visual to show parents, and that you're able to also say, hey, look, we can make the teeth look pretty, but if we don't address all the root causes of why the teeth got here in the first place, we're probably going to end up back here even after, right? I mean, it's like we see all these orthodontic relapse cases in the teen years into adulthood. I mean, I was one. And I think that now that I understand, like I had permanent lingual bars, upper and lower, and that was after, traditional RPE and braces, and, and they're like, oh, they'll fall out by the time you're 20. And at 30, I was like, can you please take these out? Because like they're coming off like tooth by tooth over the past 10 years, but like, it's so hard to clean. And I love my dentist, but I don't want to come every 3 months because I can't seem to keep it clean enough down here with, so anyways, they took them off and immediately my teeth started to shift. Like within 2 weeks, the dentist, the family friend, I was like, hey, my teeth are moving. They're like, no, there's no way those things have been on for 20 years. And I was like, no, they're moving. And I ended up in adult expansion once I got into the airway space myself, and did, a Vivos DNA appliance. I had a tongue tie release, and anyways, all said and done, I did go into Invisalign afterwards, which actually I think retracted me a little bit in the last couple of trays. So now I'm kind of like, I think we need to go back into another appliance to bring things a little bit more forward. But all that to say, like, it's so powerful, I think, when we can share like stories or personal stories, experiences, but also just show everybody, hey, like, here's who makes up the team. Here's why these components are important. So I really love that, because I just tell everyone, I'm like, I don't want you to end up like me. Okay. let's avoid this.
Yeah, no, it's incredible. So I have very similar. I did expander as a kid. I had a bilateral crossbite, super flared anterior teeth. I think I'm so lucky I didn't have extraction and retraction, just based on what I looked like as an 8-year-old. And relapsed in college, obviously, because I didn't wear retainers. And then put brackets back on myself in dental school. I had my father-in-law put them on for me, took them off, relapsed again. And then finally, when I started doing this, I was like, forget this. Like, I'm not as committed as you. I couldn't commit to wearing Vivos appliance. But I did expansive Invisalign on myself, and I opened spaces around my laterals, which I still need to get bonded. But, it stayed even when I don't wear my retainer now. So I had a tongue tie release, because it turns out all this time I've been a grade 3 tongue tie. didn't even think about it ever. And obviously like that was why I couldn't grow my maxilla. That was why I had a bilateral posterior crossbite as a kid, because my tongue was not sitting where it belonged. And it's so interesting now, like all the time, I'll just be like, tongue check. Oh, wow, it's up in the maxilla. Like, amazing. This is awesome. Like, and the tongue is the best retainer. Like it is your number one retainer, but it's also like your number one detriment if it's not doing the right thing. So yeah, I mean, my kids know all the time. They'll like look at each other and be like, tongue check. Like it's like the only 8-year-old twins who will like nag each other about their resting oral postures.
I love that. That's amazing. Now you mentioned something before too about like a lisp, basically speech issues, right? So what are your thoughts on just how, you know, and I ask this because like in the speech pathology world, there's definitely like a 50-50 split among speech pathologists. Many will say, oh, you know, myo's not a thing and you can just train the tongue where to go and this, that, and the other. And there's no such thing as tongue ties. And then there's some who are like kind of in the middle. And then there's others who are in my camp who are like, oh, hey, we've now treated, you know, thousands of patients. We see that this is the problem. We also see, at least in my experience, kids who've been in, I don't know, 10 years of speech therapy, go into an appliance if that was what was needed, have a tongue tie release with myo, you know, obviously tailored to their specific plan, and then graduate 6 months after, like from, you know, after all that was completed, but basically only needed like another 3 to 6 months of speech and just to teach them where the tongue could go. Now that the tongue could go there and they had the space for the tongue to go there. And then, oh my gosh, look at that. Like they're finally graduated. But when they started speech, they were like highly unintelligible, even as an early teenager, which is really embarrassing for a teen. Yeah. So, you know, I'm just curious, like from a structural standpoint, like, do you have thoughts on this?
That's exactly what it is. I think it's a structural standpoint, right? So this doesn't mean every kid who has a speech issue needs an expander and needs a tongue tie release, right? And I think that's what we need to be very careful about, because there's no all, right? When we talk about treatment plans, there's no every single kid gets the same treatment. You have to tailor things specifically to what you're seeing. And that's where having a broad base of knowledge is very helpful. But I, again, see kids and adults who either lisp or who have had speech therapy for a very, very long time are still pretty much unintelligible. And it's hard when they walk in as a 17, 18, 19-year-old with mom, and you're like trying to figure out what they're saying. And you're kind of giving mom the side eye, like, are you gonna help me out here? Because obviously that's not working, right? And I think that's like the big thing, even with what I'm doing. If I have a parent who's like, we're not doing anything else, we're just doing ortho. Okay, let's try, right? Let's try. I'll try it with you. We'll see what happens. And then when something's not working, you have to know what are the other options to fix this problem. And so if you've been doing speech therapy for a decade with somebody and they're having mild improvements, but they're still unintelligible, like, well, what else is going on? And I do get a lot of patients referred to me like that because, you know, the speech pathologist will be like, I'm not comfortable in this space, help me out. So we look and I'll tell you, it's like 8 or 9 times out of 10, they're going with ENT after that because they either had deviated septum, enlarged turbinates, adenoids are out of control. They're also seeing, you know, a myofunctional therapy group that I love to make sure that there isn't a tongue tie, because even sometimes I'll be like, I don't know for sure, but you know who does know? My myofunctional therapist, because she's going to evaluate every movement of that tongue and she's going to tell me if there's stress and strain. And I do think that you can probably train the tongue to go to the right space if there is a, you know, grade 2 tongue tie or compensating grade 2, something like that. But what else are we sacrificing? So like in my case, I was a grade 3 compensating to a grade 2. And by the time I started practicing dentistry, my neck hurt so much from all of the accessory muscles that were like activating every time that I swallowed, that I talked, and like I talk a lot. I try to keep my patients pretty comfortable. So I talk a lot, right? And so by the end of the day, like I was dying and I didn't know why. And when I started thinking about it, it's like, well, obviously that's why, because now I'm compensating. And I was like showing my mom, I was like, Mom, look. And she's like, oh my God, your neck is like lighting up when you talk and it lights up when you swallow. And it's like, yeah, that's why my whole back and neck hurt every day when I'm done. Mm-hmm. So just because you can get somebody to do something with more difficulty, like what is the long-term implication of that, I guess?
Yeah. Yeah. Well, I mean, that's a really great point. And I think that what we do sometimes see is like these kids can get the sounds. We can even get the sounds in words, but then when we start to string the words together, we start to lose intelligibility. It's supposed to improve over time, not decrease over time in therapy. And that's when I kind of go to, like, at least because I have a private practice and, you know, my team or anybody that I train, I'm like, hey, if we're not seeing like progress over a number of months, that should be a red flag for you. It should never get to a year or 2 years or 10 years. My goodness. Like, we should be asking, why is this not working, and be trialing different things. When we run out of things to trial, if you're not in this space, maybe we need to be referring to someone who is, because we need to make sure that structurally we have space for the tongue. And like you said, you know, sometimes we can compensate, but at what expense? And why compensate, right? When we know, I always like use this bucket example, right? Where we have like 10 buckets of energy. And for a child who's compensating, right, they may be overly compensating to speak, to eat, to keep their lips together. By the time they get to school, they're at 50% of those buckets. They have 50% energy left, versus a kid who wakes up, is nasal breathing, has none of this going on, and they go to school with 100 buckets, you know, 100% of their buckets, all 10 buckets are ready for learning, you know. And I think it's just when you start to like connect it to some type of a visual, especially for parents, they're kind of like, oh, like I never really thought about it. And, you know, I like to connect it to learning too, because we know that these kids also have sleep issues, a lot of them. And if we're not getting restorative sleep, then this is just like, it's just that big snowball that just continues. And it's like, well, how can you expect your child to do well in school, or sit still in school, or attend, or and whatnot, you know? And even if they can, and even if they hold it together all day, they are a hot mess when they get home, because they're in the negatives now. They are beyond the levels of energy.
I mean, they're exhausted.
Yeah. Yeah.
I always say to parents, like, what's the first thing you do when you wake up and you're tired? And it's like, well, I grab my coffee. It's like, okay, your kid can't do that. Like, your kid's not drinking coffee. So they're either grabbing like high sugar carbohydrates because they're exhausted and that sugar is going to give them that boost, or they're a hot mess all day. Like, and those are the two options. And it's not fair to these kids, I think, to like make them compensate, to constantly treat the symptom without looking at what is the problem. Or in worst case scenario, these kids who are getting these ADD, ADHD behavioral issues, and all these diagnoses, and I look at them and I'm like, wow, this kid is narrow. Like, wow, this kid can't breathe. Like, look at the way the nose is developing. And that's the key point, is that it's developing. So we still have the time to intervene. We still have the ability to make a big difference. And we have the ability for a long time. I think that's also what kills me, is when I talk to providers and they're like, well, the kid's already 12. Like, oh, that's it. I'm like, well, I'm treating like a 35-year-old male right now with the strongest bone structure. And like, guess what? I asked him between his front teeth, because we're opening him up and it's fine. Like, we can do it. We just have to do it appropriately. You have to have the knowledge base. You have to have the plan in place, and you have to have the team working behind you to make sure that what you're doing is going to work.
Yeah. Or on the flip side, you have a lot of providers saying, oh, well, let's just wait a year. And the child's already like 6.5. I took my daughter down here to somebody who's really well respected, and that happened. And I was like, she's 6.5. She's had pre-ortho, like with the ALF. She's a really great patient. She sits still for, you know, CBCTs. She's primed and ready. Like, this kid is ready. And they're like, come back in a year. And then I took her to another one, and it was like, well, she's got some shark teeth down there, and, you know, this, that, and the other, and she's beautiful. I don't know.
Have her push on it with her tongue.
Yeah, that's exactly what I was told. They were like, well, we're going to have to pull those lower central incisors, the baby teeth. And I was like, hold up. Our dentist said she's got 6 months. Let's see if they come out on their own. And they did. And of course, because she does have that tongue forward posture that she's in myo for, that she needs the appliance for, you know, we did grow the mandible forward. She doesn't have enough space in her mouth currently. And we're kind of debating, like, do we need to redo her tongue tie release? Like, what, like, we're on the line there right now, but she did push her teeth forward with her tongue. And I was like, that does not seem to be a good treatment plan. I'm not sure I like this very much. I mean, okay, fine. She brought them forward, but like, that should not be the answer that we get when we go to an ortho's office. So
you know what? I have never seen shark teeth or the double row come in a kid who has space, ever. And I mean, maybe there's a provider out there who's going to prove me wrong, and I would love to see that, honestly. But in a kid who has space in their lower jaw, picket fence spacing, as the adult teeth are coming in, those teeth come in correctly. So like, to me, when I get so many parents, because my kids play a lot of like sports and they're in a lot of activities, And as soon as they find out I'm a dentist, oh my God, my kid has those shark teeth. I'm like, can you bring them in? Like, can we take a look?
Yeah.
But then they're like, oh, my dentist said it's normal. Like, okay, normal, like common, yes.
Yeah. Well, and isn't it,
No.
so, I mean, and this was how it was explained to me. So isn't it that like, as the adult teeth come in, assuming there's enough space for them to come in where they, you know, in their proper placement, aren't they supposed to like, isn't there that resorption process that basically starts to resorb the root or something? So it makes the teeth wiggly, they fall out and then out erupt the adult teeth. Isn't that like the, okay.
That's
so
exactly
the
what happens.
Okay.
So if like the spacing is correct in the mouth, what I always tell parents when we talk about guiding appliances in myofunctional orthodontics, teeth are going to follow a path of least resistance into the mouth, right? They're not going to fight to try to come in over something else. But the tooth buds on the adult teeth come in just lingual, like just a little bit towards the tongue. If they're way back here, it's because there was nowhere for them to go, right? So they should be coming up and they should be resorbing the root of the tooth right in front of it. But now, and I don't know that I have not read research on this. This is my personal opinion. But as that tooth comes in, if it's got to bang up against like 4 other teeth in there because there's so much crowding in the bone or in the mouth, right? Then why would it come up here? It's going to come in back here where it has space.
Yeah.
And it's exactly not going to resorb the root, right? It's not going to resorb the root. And then those teeth are not going to get wiggly enough.
Yeah. Yeah. So, I mean, basically it was like, all right, start wiggling those teeth. If we have any hope here, we can get them out ourselves. And, you know, I was very thankful that they came out themselves, because I'm like, look, if we can avoid pulling teeth out of my child's mouth, like that's a little bit more traumatic than them falling out on their own. So was very grateful for that. But I was just like, oh man, so now we're driving an hour south to basically a functional pediatric dentist she only works really like with birth to 12 and likes to get them in early. And so she's seeing both of my kiddos and we have a really great plan in place now. But I was just like, man, like there is no, like, I can't find anybody in the Boca Raton area. Like what gives? We have to go to North Miami, which is fine. But
no,
I was spoiled up north where I came from.
I know. It's funny too, because anytime I go, I'm in Fort Lauderdale, where I grew up. So like anytime I go back to see my parents, there's a dentist on every corner. I mean, there's 2 dentists in certain plazas, and there's nobody in the airway space within the like Boca, Fort Lauderdale area at all. And I mean, I think my neighborhood, we went to like 4 or 5, there were 4 different orthodontists who all treated every single kid. And I don't know. I think just from a pure practice management point, like get into this space. It's an amazing space to be in, and you treat your patients and they are grateful for a lifetime, and you change the way that their whole life is going to play out for them, especially the kids when you get them young. Because if you can get a kid sleeping, and yeah, that was another point I wanted to make. I'm terrible at this, but the idea was it's not just sleeping, right? So, and I think that was one of my big issues with like mandibular advancement appliances, is that we're treating sleep and we're only treating sleep, but it's not sleep, it's airway, right? And so a person who has a bad airway at night has a bad airway during the day. So it's not just that they can't sleep. I mean, yes, they can't sleep, but they can't breathe well. Like maybe they're getting tired while they're playing sports or running around on the playground with their friends, and, you know, mouth breathing, and then the asthma's hitting them and the allergens are all blowing up the back of their throat and all the lymphoid tissues back there. It's not just sleep. You're changing the airway of these children. You're growing their entire airway. You're growing their face. Aesthetically, they look better, obviously, because wide, broad smiles and faces that have grown to their full potential just look better. So now they sleep better, they breathe better, they can play with their friends better, they can speak better, they have more self-confidence. Yeah, I just see that as a much better outcome than waiting till they're 12 and moving some teeth around.
Yeah. Well, I mean, and research shows that basically the most critical period of development for our brain is birth to 7. And so why are we waiting until after that point to start giving them the ability to fully, you know, oxygenate their brain? I mean, it's like, it doesn't make sense to me when we start to actually read the research and we start to look at these cases. You know, we're not doing any harm to these children. If anything, it's harmful to wait, right? We're helping them. You got to get in there early. And the earlier and earlier I see this happening, the better off these children are, because like my private practice goes and works with, you know, we work with pediatrics, but we see mostly like, say like birth to 10, maybe. Like we do work with older kids and we do myo with all ages across the lifespan. But we work with a lot of those feeding kids. We work with a lot of those speech and language delayed children. Sure, we've had cases where after a tongue tie release, the child just starts talking. Like we never promised that because, there's nothing that I can really say, okay, the child can't talk because they're tongue tied, but have we seen it? Yes. Is it in every case? No, but it's just amazing to see like systemically what happens because of a child being able to sleep and get restorative sleep and have full access to their articulators and use that tongue, to hold the palate shape once they've had expansion and just all these various things that I feel like are being missed in a lot of the traditional orthodontics.
Yeah. I mean, we've seen kids hit growth spurts after
Oh
expansion.
yeah.
Just all of a sudden shoot up. And I'll always say, it's crazy. I'll see them and then I'll see them for like a 3-month follow-up. And I'm like, oh my God, is that your child? It's like, yeah, well, all of the growth hormones that were supposed to be cycling appropriately, like weren't because the sleep cycles were totally off. And, yeah, it's just really, it's really interesting how just changing the way a kid breathes will change so many things in their life systemically. And
how young are you seeing like deviated septums?
So I think the youngest I just saw was like a 4-year-old or a 5-year-old.
I just had mine corrected,
ENT.
so it's like, man,
yeah,
4. Scary.
Yeah, and
It's actually
turbinates.
scary.
Like the turbinates are like a really big thing.
Yeah.
And I don't know. I'm pretty sure in the 4-year-old case, the ENT said like, I'd like to see what we can accomplish non-surgically at this point, right? And that makes a lot of sense to me. But when we take a pan. I know there are a lot of providers doing cone beams of the whole airway. I'm not at this point, but I will take a pan and a Steph on pretty much every kid I see to look at skeletal relationships. I can see enlarged turbinates in so many of these cases. And a lot of the times you see the soft tissue literally touching the septum. And it's like, how are you breathing out of your right nostril? Oh, I don't.
Yeah.
Or I'll be like, do you feel stuffy on either side? Yeah, my left side's always stuffy. And I'm like, well, this is why.
Yeah.
Let me show you.
Yeah, that was me. And I actually think that like I hit a wall in my expansion. Now, I admit I wasn't like the best patient because I was treating and like I only wore my Vivos like 8 hours a day instead of the 16 that they wanted me to wear it. It took me like 2 years to get to where I got to. My max was in on one side. I'm a whole mess. But I also realized like, well, I didn't deal with my nasal cavity. I didn't deal with my ability to breathe, which is probably why I was like more locked up. I was working with other providers, like a PRI trained PT and a holistic dentist who was doing this with me and, anybody else I was referred to. But I just had actually in April, I just had a septoplasty because I was straight in the front. So you wouldn't have like really seen it looking at me much, but I deviated back towards the left and the back and it was completely blocking the left side. Then I had enlarged turbinates. Then I had enlarged nasal swell bodies, which I had never heard of before. So I'm like, oh, great. I've got like swelling coming from the outside in, swelling from the inside off the nasal septum out. So basically my ability to breathe through my nose, especially when I lay down, is now just, tanked. And so I did a home sleep test before I went in for the surgery just for information. And with the goal of doing it again, once we feel like all the swelling is down, because I also did a rhinoplasty. And so I'm like, maybe 6 months, maybe a year, we'll see, or maybe I'll do it at both points. Who knows? Cause I'm just curious to like, I feel like I'm breathing better, but I feel like there's still more work, for me to do. And what it showed was that I would traditionally not have been like picked up as someone with sleep apnea, but definitely have UARS. My body was like every time I went into REM sleep, like in the first 2/3 of the night, my body was like, yeah, no. And it would kick me out of REM sleep. So I was getting like no deep sleep. And I'm like, no wonder I'm always exhausted, but I wasn't really having like that true like sleep apnea. I had some apneic moments, but nothing, significant enough that anybody would have diagnosed me. So it was very interesting to have that information and to have those kinds of answers. But that's also, I'm like, I hate putting kids through this kind of information and like these types of tests. I'm like, no one's going to sleep well in a lab. And then like how accurate is a home sleep test with a kid at home?
They're actually not FDA cleared for kids at home, or at least in my knowledge. I don't think there are any that are home sleep tests.
Most of my providers don't require them. Sometimes insurance will require them. And we have had some cases where like an ENT was like, this is emergent. I want this kid to go for a sleep study like immediately. And then like the next week tonsils and adenoids came out and I'm like, okay, that's a specific situation. But I'm like, we can see behaviorally and structurally enough to know why the child's acting the way they are. And I was actually in my daughter's bed last night. She fell asleep, and this is the one who has the history of croup, who's getting ready to go into expansion. And she's like flailing all over the bed. And like, her mouth was closed, but she was flailing and kicking and making noises sitting up, but like not responsive. If I was like, hey, Mia, you okay? You okay? Like not responding to me, like clearly, not really having a night terror, but like also just totally out of it. But that's not normal. And this was going on. Like I just stayed there for a while to watch her. And I even recorded it because I was like, okay, what is going on? Like, this is not normal even for her. So I'm like, these are the kinds of things where like parents are like, oh, well, sometimes my kid kicks around a little bit, but I don't think it's anything abnormal. I'm like, no, we should be quiet breathing, mouth closed. You should not, like, no audible breathing. Body should be relaxed and still while we're sleeping. We should not be flipping all over the place in our bed. So I do feel like it's one of those things, if like we watch long enough, we can usually see on our own kids, but a lot of parents are like, I think they sleep great. I'm like, let's look into that a bit more.
Yeah. And I think like sometimes those baby monitors that you totally got rid of when your kid was like old enough, those are amazing to pull out, because for one night, just like put it in the room, even if it's just like, so my kids are 8 and I feel like everything changed in like the baby world. As soon as I had them, there were like camera monitors and the like links to your cell phone. And so the technology changes quickly, but even if all you have is like the volume one, you'll be amazed at the amount of noise that comes out of their room at night. Like whether it's snoring or just breathing or speaking or tossing and turning, like you can hear that on one of those monitors if you turn it up, and then you won't sleep all night because you'll hear it all night long.
Yeah.
And it's not normal. It's not normal. And I always have parents, I'll be like, well, how do they sleep? Oh my God, they go to bed at 7 o'clock. They're exhausted. They go right to sleep and they don't wake up until 8 o'clock the next morning. And I'm like, okay, how are they sleeping in between 7 o'clock at night and 8 o'clock in the morning? Well, I don't hear from them at all. It's like, okay, maybe let's take a look at this, because I have a feeling that maybe those hours of sleep are not as productive as we think they might be. Mm-hmm. And maybe we can come up with some strategies to help that. And honestly, in the case of your daughter, if that was something that's happening like all the time, that's one of the kids I might send for a sleep study, an in-lab sleep study, because I want to know what else is going on, right? I as a dental provider, I can certainly treat any apneic events, and I'll have the sleep doctor send things to me all the time. He'll be like, I think there's more going on here, but this kid has apnea and let's get rid of that first before we can figure out what else is going on. Because I've spoken to a couple of pediatric sleep doctors lately, and it's like the number of diagnoses that they deal with the limited amount of data that they get from an in-lab sleep study, being able to parse all of that together with the parent history, that is not my job. And I'm like, that's just an honest statement. I don't want to be doing that. I want to deal with what I know is going to help these kids. So like, if there are frequent things that are popping up that, sound like a REM disorder, right? I want them to be seeing somebody who may be able to fix that or help with that. And yes, I'll help with whatever part it is that's mine. But like, I don't think every kid needs a sleep test. I truly don't.
Yeah.
I think some of the kids, you look and you see very obviously what's going on. So now say we fix that. And this goes back to the idea of having a lot of tools in the toolbox, right? We expand these kids, we make them nice and wide. We send them to the ENT. The ENT takes out the adenoids and the tonsils and does the turbinectomy and, make sure that this kid has no structural issues. And I make sure the kid has no structural issues. And the myofunctional therapist is working with them. And the kid is still waking up in the middle of the night, talking and walking. Okay, we got to get them to a sleep doctor at this point, because we're not just going to say that's fine. Like, oh, well, we already dealt with all the problems, so they're fine. No, they're not. Yeah. They're still not fine. So now we've dealt with many of the problems, and let's see what else is going on. And that's where having that collaborative team is just like the most important part of treatment.
Absolutely. Yeah, no, we had done a CBCT. I took her to the ENT. We've done a number of things with her, and she's been to an allergist and pulmonologist and all the things. And it's so interesting too, because I started back when she was like 2. I remember the first time I took her to the allergist, and they did the whole test, and they're like, well, everything looks negative, but it's not really reliable with a 2-year-old. And I was like, okay, then why did we just put her through that? Like,
I know.
What is that all about? It's like, so that's where I start to like pull back as a parent. And I'm like, okay, Like, what is the priority here? Like you're saying, like if a child is flailing like that when they're sleeping, we go, whoa, this is screaming airway. Like something is going on. Like, let's address this. And what is the right treatment plan for this child? So I love that you're very individualized in terms of like, okay, we want to be, it's hard to be like least invasive, right? We don't want to send every child for a surgery, but it's like, what can we do behaviorally? What can we do structurally without having to like send them for something surgically? And then if we feel like, okay, this child needs more, like, let's talk about what's next. So that's very similar to like the approach that like my team and I take. And so I always appreciate that because I'm like, it's a lot. And like, as a parent of a child or two children going through this, it's overwhelming even for me being in this space. And, I think that like one of the plans was is to put both my kids obviously into we're doing rapid palatal expansion for them, but we're using a high rax that also does forward growth. So, and it's going to be upper and lower. And in the meantime, the dentist wants to like build up their, my youngest bite, right? So the plantar track. So we're going to build up her bite a little. We've been using Myo brace with her a little bit just to kind of get some more space because she's such a deep bite and she's just, obviously grinding away at those teeth. But she just won't sleep in it yet. And I'm like, if we could just get you to sleep in this so that your jaw is better positioned. I feel like that would be like a good Band-Aid for the moment until we can get you into like the rapid palatal expansion. We're just waiting. I think we're going like in the next week or two, to actually get things moving along. But yeah, it's just so interesting. And it's also very interesting to see like different dentists in this space taking like different approaches. And I'm like, I don't care what approach is taken as long as it works. As long as we get my child healthy, like you tell me what you recommend. And I think that's something also that we don't talk about enough because people get really stuck on a single appliance because they've heard it works.
Yeah. Yeah. So like right now I don't do like an ALF. It's just not in my toolkit. And I am very happy to send anybody who is like dead set on that to somebody else. But for me, like an ALF is very slow. It's like a very slow expander. And a lot of the kids I'm getting, again, they're very symptomatic. And I want a 3, 4, 5-year-old out of symptoms. And I want them out of them quickly. I don't want to take the time to slowly develop the arch if they need to do it quicker. And if I am slowly developing the arch, then I'm doing it with myofunctional orthodontics. So I think there's too much on the exact appliance and not enough on the overall treatment plan, the final goals, and like where these kids need to be. So yeah, I think having like a really strong background in orthodontics, period, is very important. So a lot of these like weekend courses that you take and you learn an appliance, it's great. But until you have like that whole background to understand growth and development, to understand like what you're actually seeing on the Ceph, the cone beam, like all of these things need to come together. And so, one of the major courses I'm taking is through the International Association of Orthodontics, and it's a 2-year fellowship. We meet 4 times a year. We review all our cases. Like we go through every single aspect of it. And I thought that was super important if I was going to be doing this, because you need to have that basic understanding. They're not teaching as much of this early intervention, but I get that from everything else I see. I think everybody should have a good basis in all of it if you're going to be doing it.
Yeah, no, I definitely can appreciate that. One of my dental colleague friends went back to school. He's up north, but he went back to school for orthodontics, like midlife. And so I've sent him the kids' cases and I'm like, okay, like, what do you think? What about this? And this is what this person said. And he's like, okay, this person thinks she looks great. No, like her mandible needs to come forward. Her width she got some great expansion with the ALF, but like it didn't bring her mandible forward enough, and we really need the jaws coming together and so on and so forth. And so it's nice, like you said, it's nice to have somebody with that background and understanding who gets it from various levels, because, he was a restorative dentist before and basically sold practice and went back to school for ortho and is now completely practicing in a different space. And so it's really exciting to see this. And, I'm like, I'm sure people think I'm crazy because my kids are like, ortho at the age of like 4, but I'm like, I don't care. Like, I want my kids to have the best lease on life. And this is, it's like you said, when you see it, you can't unsee it. When you know it, you can't unknow it. And, I'm like, I wish I could have started them even earlier, but here we are. At least we're doing what we can do now. And that's what I try to tell everybody too. I'm like, there's so many appliances out there. There's so many different approaches to helping the airway. And I think the most important thing is that you figure out what provider you jive with. Hopefully there's somebody close to you, and see what they use, see what they recommend, and just don't, because everyone would get so focused on like the ALF when they would talk to me, because Lily had that. And I'm like, that was step one. Look, she needs another step. Like maybe Mia going into this appliance first, maybe she won't need an initial step. But who knows? I don't know. That we won't know until later. So
every kid's different. Every kid is different.
Yeah.
Right. It's like some of them, like you fix the one problem and that's it. They are like free, they're flying, they're good. Other ones, like there's a lot more going on and the growth just doesn't quite hit it. And you still have to go back and do things. So
yeah. Well, I love everything you're doing and appreciate, all of the teamwork and the collaboration with Myo. And I think it's so fun to meet providers who are in this space. So thank you.
Yeah. Thank you. Thank you for having me on. It was really cool. Cool to talk to you and get to know you guys.
Glad that we got to chat.
Yeah.
Thanks for listening to this podcast. If you want to hear more of these Myo, Tots, airway, and feeding related episodes, be sure to leave a review on Apple Podcasts or pledge a small amount on patreon.com/the Untethered Podcast. If you found value, others in this space will too. So be sure to share this episode on your social media platforms and join us over on Facebook, on my Facebook page at Hallie Bulkin Biz, on Instagram at Hallie Bulkin, and you can head over to theuntetheredpodcast.com to grab a copy of the show notes, where you can also subscribe to be kept up to date on the latest podcast episodes.